Welcome to the Mountain West AETC Project Echo, and I'd like to turn it over to our speaker for the talk today.
Thank you. Thank you for having me here. Definitely appreciate the opportunity to talk a little bit about our program. So as David said, this is going to be about our one-step PrEP program, which is a pharmacist-run HIV PrEP clinic in a community pharmacy setting. So for today, I'm going to start off with going over some of our clinic operations to give you an idea of how we operate the clinic, and then we'll discuss some program requirements in the event that anybody wants to replicate a program similar to us. And then I'll talk about our clinic data from our first year of operations. Okay, so this is a photo of Kelly Ross Pharmacy, which is an independent pharmacy located in Seattle, Washington. And as you can see, we are a traditional community pharmacy site. And so patients can just walk up to the counter, pick up their medicines, their lisinopril, any other chronic medications or acute medications. Off to the left of the screen behind us is our over-the-counter section. And then down towards the right of the screen, down that long hallway, which you can't quite see, is where our patient counseling room is. And that is where we see all of our PrEP patients and our appointments. And so for years, pharmacists have demonstrated success in managing all kinds of different disease states, including anticoagulation, lipids, diabetes, and a whole slew of other things. And we basically just decided to take that exact same model and apply it to PrEP in a community pharmacy site. And so we operate our clinic as one-step PrEP, and we call it one-step PrEP because a pharmacist can, or a patient can essentially walk into the clinic and get all their screening done, all their testing, their prescribing and dispensing, and if they qualify, can even walk out of the pharmacy the same day with their medicine. And this is all done under a protocol or a collaborative drug therapy agreement known as a CDTA under a physician medical director. And our physician medical director is Dr. Peter Shallett, who is an HIV specialist here in Seattle. And we started our clinic in March of 2015. So I'm going to talk a little bit about program requirements and some of the barriers that we had to overcome. And some of these requirements require state legislation, legal laws that have to be overcome, and then also some licensing requirements as well. So the top three barriers that we had to overcome when we were creating our clinic include making sure that it was within the pharmacist's scope of practice to prescribe and order labs. And then we also had to look into ways for billing for services, because traditionally pharmacists are not recognized as providers by insurance carriers to bill for a lot of our medical services. And then lastly, we had to find a way to obtain labs. And this is because Kelly Ross Pharmacy is a community pharmacy, and we have no real true affiliation with a hospital system or a real healthcare system. And so we needed to find a way that our patients could obtain labs. And to address the scope of practice question, Washington State specifically has something written into the law, into our code, that allows a pharmacist to initiate and modify drug therapy based off of a protocol or a CDTA under direction from a physician. And Dr. Peter Shallett is our physician, and so we wrote up this protocol, the CDTA, and submitted it in and got it approved by our local Department of Health. And that is how we are able to prescribe and order labs as necessary and basically do all the follow-up and treatment as necessary for PrEP. The second barrier we had to overcome was, how do we bill for services? So like I mentioned, pharmacists traditionally are not recognized as providers by insurance carriers. And so for the first 2 years of our clinic operations, we actually made it a patient responsibility for them to pay for their services. And we wanted to make sure that it was not a barrier, so we picked some fees that we felt like were pretty standard copay amounts, so the patient would be responsible to pay that for their service fees. And then most recently, in January 2017, Washington State's Senate Bill 5557 went into effect. And this is a landmark provider status legislation that requires health insurance carriers to recognize pharmacists as providers to allow for billing. And currently, I believe Washington State is the only state that actually allows pharmacists to do this. And so as of 2017, we have been billing our medical services to these insurance carriers, and they have been reimbursing us for our services. The third and final barrier that we had to overcome was laboratory testing. And we decided to try to do as much testing as we could off of CLIA-waived test products. Pharmacists are well versed and trained and experienced in finger sticks, and so we felt like we were the most comfortable doing that. And so CLIA-waived license, we applied for a CLIA-waived license, and we have that, and we posted up on our wall. And basically, it just means that we have a dedicated patient space, lab processing space, and that we maintain our competencies for knowing how to get these tests completed on a patient. However, there are some tests that do not have a CLIA-waived product, and so again, we need to define, well, how are we going to get some of these other labs completed on our patients, including blood draws? And so we decided that our pharmacists should become phlebotomists. Alternatively, if you don't want them to become a phlebotomist, you can definitely set up a contract with whatever big box lab in your area and send your patients down to those labs and get the labs collected there. That's fine too. We just thought for ease and for accessibility, we would have our pharmacists become phlebotomy licensed. And it's currently not within the scope of practice for pharmacists to practice phlebotomy. And so we decided to just go and get our phlebotomy license. And every state has different training and licensing requirements. There are some states that are fairly easy to get your phlebotomy license, like California, Missouri. Those tend to be a little bit more convenient. Washington State is a little bit more rigorous, but still doable and can be easily done in a short period. So, all right, so let's talk about some clinic data first. So let's see, from March of 2015 to March of 2016 was the first year of our clinic operations. And we saw there were a total of 373 patients seeking our service. 251 of those were evaluated in our clinic. 245 of those qualified and initiated PrEP through our service. And it's interesting to note that only 57 of those patients actually stated that they had an existing primary care provider. So this suggests that most of the patients seeking our services were not connected to care in any other way. Patient characteristics. Most of our patients, 98% of them, were male. We did have 4 female patients and 2 transgender men patients. At that time, we did not have any transgender women, but we do now. The average age of our patient is 34, and the age range that we see in our clinic is anywhere between 18 to 64. 84% of our patients identified being MSM, and their average MSN index is 20 plus or minus 7.2 of a standard deviation. And this suggests that we are accessing a pretty high-risk population. 4% identified being bisexual, 28% identified being in a serodiscordant relationship with an HIV-positive partner, and 1% indicated that they are an injection drug user. Other clinic discoveries during our first year of operations. So we had 26 bacterial STI diagnoses, the majority of them being chlamydia and gonorrhea. We did have 2 patients that screened positive for HIV. 1 person screened positive during the initial screening, and 1 other person screened positive during a routine follow-up appointment. It is a program requirement of ours that if you do not have a primary care provider, that you establish care with somebody within a year of starting our service. And so during that year, we were able to connect 40% of our patients up with a PCP. Clinic retention, we had a 75% clinic retention rate. 25% of them discontinued our services, and Majority of them did so because of insurance restriction or transferring out for care. There were only 13 patients who were lost to follow-up, and other reasons that people discontinued our services included a decreased risk perception or moving out of the area. So our staff works really, really hard to ensure that all of our patients can afford their medicine. We have a phenomenal clinical coordinator who manages all of our billing and patient assistance programs, and 97% of our patients pay nothing for their drug every month. And then clinic viability, for those who are looking to replicate our program, most folks don't want to replicate anything unless there is some kind of return on investment. And we were able to see a return on investment at just a little bit over 8 months. So in conclusion, one-step PrEP is feasible through a CDTA with a physician medical director, and there's definitely enough patient demand to support a service such as this, and our high retention rates does show a pretty high patient acceptability to support a delivery model like this. And our clinic proves to be financially sustainable at about 9 months. I'd like to take a moment and thank all of my colleagues who have helped create this clinic. Off to the left, we have Annalisa Thomas, who is another pharmacist on the service with me, and she helped me create this clinic. A lot of her first year residency was dedicated to this. And then off to the right, we have Allison Eichner, who is a pharmacist that we brought on at about 1 year. And in the back, we have Troy Hart, who is our clinical coordinator.